Hey, good afternoon, everyone. Happy New Year, and welcome to today's webinar, how hospitals are publishing price transparency data and steps to create a competitive advantage in 2021. So I do see some people continuing to dial in, but it is 2 o'clock, so we'll keep moving forward here and get started with today's session. So just a couple of items before we start digging into today's topic, and we have a lot to talk about. We have 1 hour scheduled for today. The actual material should cover about 45 minutes or so, and we did leave some time at the end for questions. So there's a lot of material to cover today, and so I definitely encourage you to ask questions throughout the session, and we'll take that at the end. If you think of anything you'd like to ask our speakers, go ahead and enter that into the questions tab in your GoToWebinar panel. The second thing I'd like to point out is that we do have some in-session offers for our attendees today, and those will be coming through your chat window. So you'll see at some point during the session, you'll see your chat bubble light up an orange color. So be sure to check that and see if that's something you might be interested in and can help you and your organization through this new era of price transparency. So with that, let's welcome our speakers today. My name is Brad Josephson. I'm the Marketing Director at PMMC. Also with me today is Greg Kay, Senior Vice President of Revenue Strategy. Welcome, Greg. Thanks for being with us today.
Hi, everyone.
And also joining us is Tara Bogart, Vice President of Revenue Strategy here at PMMC. Tara, thanks for being with us today.
Brad, thank you for organizing today's virtual conference. You've been really great and diligent in scheduling these educational sessions for our clients. So on behalf of the clients that I've personally helped over the past 12 months in the price transparency area, we certainly appreciate you routinely scheduling these events. So for those of you who don't know PMMC, we're a privately held revenue cycle firm that focuses on accurate contractual reimbursement calculations. And for the past 35 years, we've leveraged this data for payer analytics, prospective contract modeling, patient estimates, strategic pricing, and over the past year, price transparency prep.
Gosh, Tara, has it been that long? This past year, preparing for price transparency really seems like 3 or 4 years, but obviously 2020 was a crazy, extremely long year for everyone. And I think for most of us, it had nothing to do with price transparency. And Brad, as Tara noted, we certainly appreciate you coordinating today's session and all of the behind the scenes efforts that you put into this throughout 2020 and today. For all the attendees, I want to also extend a huge thank you to several of our team members, Heather, Johnny, Jeff, Chris, Chad, for their assistance with really reviewing hospital websites over the last couple of weeks, gathering over 450 hospitals and healthcare systems websites, and really using this data to aggregate baseline information for today's discussion. I think it'll be extremely helpful for everyone on the call. And this obviously couldn't happen without a very dedicated PMMC team that's not just focused on preparing for price transparency, but really looking further out into 2020 and 2021, 2022, with how we can actually help our clients leverage our calculation engine and the new standard charge data that's out and available, along with the quarterly CMS standard analytic files, for us to really have a better handle on market pricing. And by that, I mean both leveraging all components of the new pricing data files, including the gross charge, the self-pay, cash price, and the negotiated charge by payer and plan posted for each hospital.
That's right, Greg. And many of you on the call today already understand PMMC's approach to price transparency, that it's not just a single step of creating a massive file with only a few people actually reviewing it, but that's just one component of it. It's truly having an integrated revenue cycle process that builds on an accurate contract governance process. And we refer to that as our revenue maturity matrix. It's an integrated approach which moves to eliminate the operational silos that so many of you have right now between managed care, patient accounting, patient engagement, charge master, all those areas. Accurate contractual calculations really drive the collection of your contractual reimbursement, but it no longer can just stop there. Contract governance has to be the baseline for you to start creating those transparency files, negotiating your future payer contracts, proving your patient engagement related to price transparency and accurate estimates to really get some market competitive advantage and longer term develop your population health strategy.
So with those introductions, we'd like to get some feedback from the audience on how you guys are doing with the price transparency mandate. So we're going to kick it off with a poll question, and our first poll question here is, how did your hospital comply with the standard charge file requirement? So this was one of the key requirements in the mandate. And the options here are, we posted the standard charge file only. We posted the negotiated charge file only. We posted both the standard charge and negotiated charge file, or we did none of the above. So please get your vote in. Let us know how you're doing with this requirement, and then we'll go ahead and share the results. So I see about a third of the audience has voted so far. We'll give everybody about 10 more seconds here to vote. I see the votes pouring in. And after you guys submit your responses, we're going to share how the broader market has responded too. All right, so it looks like the majority of people have voted. So let's take a look at this real quick. So the majority have posted both the standard charge, the majority on this call at least, have posted both the standard charge and negotiated charge file. That's 68%. 16% posted just the standard charge file only, and another 16% has yet to post either. So thank you for your responses there.
In today's session, we're going to focus on several key topics that will help drive success with price transparency in 2021. So first, we'll review the baseline price transparency requirements and the results of our market assessment over the past 3 weeks of what hospitals have actually posted and how that data compares to what was actually required by the mandate. The second thing we're going to do is review ways to effectively leverage this data and key analytics that you need to be leveraging in the new world of price transparency. And then finally wrap up the discussion with a few analytical concepts as we move forward on how to balance price transparency and net revenue. We really just want to make sure that you're using this price transparency data to build your offensive and defensive plans for your payer engagement.
Okay, so with that as a level set, really beginning back the first of the year, January 4th, PMMC's team began reviewing targeted hospitals and healthcare system websites. The healthcare systems that we selected were organizations with 3 hospitals or more and individual hospitals that were typically larger, if you will, 250 bed regional hospitals. And this initial group for our survey represented about 1,300 hospitals in 39 different states. We intentionally did not include smaller hospitals at this time, as CMS will likely focus their audit review on the larger healthcare systems. We also initially excluded our clients from the survey to not skew the results, as we believe they do have files that meet the mandate. Brad, anything you would want to add?
No, I think this covers it. We really wanted, kind of speaking to your point, Greg, we really wanted to get a broad view of the market, really to kind of understand where everyone is. So we tried to go as broad as we could within the first 3 weeks of this being active. So
so let's look at some of the results, Brad.
Yeah, so let's first look at the charge file requirement. So let's first look at what percentage of hospitals have actually posted the machine readable standard charge file.
So from our assessment, we found about 77% of the hospitals have a standard charge file listed. Now, that means nearly a quarter of the hospital websites that we reviewed did not post a file that we could easily find the file. And when we said easily find, that meaning 4 clicks or less, or we couldn't find it through the hospital website search bar. And I think this is fairly similar to the results we saw in the poll question a moment ago. Now, do keep in mind that this doesn't mean the 77% of the surveyed hospitals that we did posted a file that's compliant with the 2021 requirements. The 77% really only represents that we found a standard charge file as an initial baseline.
Yeah, and then the second piece we looked at, really to provide some additional insight, was whether the posted standard charge file was compliant. And then one of the metrics that we quantified was whether the posted file actually contained the negotiated charge information by payer. And here's what we found here.
Yeah, that's right. And with the hospitals that actually posted a machine readable file, about half actually included the negotiated charge data with the payers. We obviously don't know if it included all payers and plans as CMS stipulated, but this was really a tally of whether there were some payer-specific negotiated charges listed in the file. And I should add, the majority of the time when we found the negotiated charge data being listed, the hospital file that was posted also included the other required data elements, such as the CPT HCPCS code at the charge code level. It included the cash price and the de-identified min and max charge value. So really combining the two for all hospitals surveyed, our results found about a third of the hospitals actually have the core CMS outline criteria to meet the mandate.
Yeah, so let's explore the standard charge file a little bit here, Greg. So for the hospitals that posted negotiated charge data, we wanted to look at the results really of what was in that charge file.
Yeah, so as we reviewed all the charge files as a part of this particular initial market assessment, first off, it's suffice to say that we saw a very wide range on the number of payers with the negotiated charge. CMS did indicate it needed to be a list of all payers and all plans. They obviously excluded Medicare and Medicaid, and our review found a range from 2 payers to 100 plus, and on average, there was about 27 payers listed when the negotiated charge data was included. And really based upon our contract management experience that Tara touched on earlier, with loading payer contracts to calculate the expected reimbursement, for our clients where we provide contract management services. On average, we typically maintain 30 to 40 payer plan contract profiles per client. So the bell curve as you look at the number of payers listed, it does highlight a wide range. And we would expect CMS to request hospitals that they do find things that are questionable. They're probably going to be asking for additional support documentation. And we think the number of contracts that you have listed is probably going to be one of those areas. Similar to the number of CDM lines in the posted file, we saw a wide range, everything from a low of 3,300 to in excess of 100,000 lines. 24,000 lines seem to be a reasonable but moderately low average, especially when you consider CMS request with tiered pricing information being included. And when you consider you're listing the full CDM along with the negotiated charge values for all items and services, which would be those DRG based services, you obviously would see something else listed there. And then in terms of the specific file format with what we found, overall, 68% of the posted files were in some version of Excel. 10% of the files were in a CSV format. 9% were JSON file formats. And really 10% was a mixture of other scenarios, including we did see several PDF files, which is not compliant. We saw text files, and we also saw a small percentage of searchable online tools that did not appear to be easily downloadable in terms of the full machine readable file. So we would question whether in the long run those file tools are actually compatible. Probably some more research will need to be done in those areas to be sure that that data is easily accessible as CMS required.
Yeah, and now let's shift into the shoppable file requirement. And Greg, if it's okay with you, before we get into these stats, I'd like to poll the audience on how they've responded to that, and then we can look at our broader market stats. So our second poll question is, how did your hospital comply with the shoppable services requirement? And then the options here are, we posted the shoppable services file, we added an estimation tool to our website, we posted both the file and an estimation tool on our website, or we did neither. So again, that question is related to the other big piece of the requirement. How did your hospital comply with the shoppable services requirement? And I see votes coming in quickly, so we'll give everybody here about 10 more seconds to get their votes in, and then we'll share those results. All right, let's take a look at this. And this will be interesting, Greg, to compare to what we saw in the broader market. So the audience today, most posted an estimation tool, 46%, almost half. Another 27% did both the file and the estimation tool. 14% posted the shoppable services file, and then the remaining 14% has done neither so far. So, Greg, how does that compare to our overall market?
You know, it matches up pretty well. And matter of fact, I would even go as far to say that the audience today is probably even more compliant than what we saw in the overall market assessment that we did. In terms of the results that we saw, nearly 3/4 of all the hospital websites that we checked either had a posted shoppable file or a patient estimation tool. Just over 20% elected to post a shoppable file, which is pretty close to the survey results here. And we've seen through that analysis, just over 50% of the hospitals in our assessment did have some type of online self-service estimation tool. I think from our survey results here, when you combine, they did both or just the estimation tool. Our participants today did a little better than the market as a whole. Obviously, you're attending this session, so this means a lot to you guys, and you want to be compliant. I think it's important to also provide some perspective that when the need for increased price transparency was first announced back in late 2018, we did a similar market assessment. And at that particular point in time, we found about 10% of the market, the hospital websites that we surveyed then had an online estimation tool. This time last year, we did a similar survey, and that survey found about 13% of the hospitals. And here we are a year later with more than 50% out of that whole survey group with an online estimation tool. So in hospital timeframe, that's moving quickly. I mean, when you think about what the industry's done over the last 2 years, so we've definitely seen a shift towards incorporating estimation tools and really trying to meet the market in terms of consumerism. So, Brad, is a quick level set. Let's look at CMS's price transparency requirements and really what they. So, as I was going to just share, is a quick level set. I think everyone knows and understands with the requirements here January 1st. There are really two pieces, and that's what we did our market assessment around, that comprehensive machine readable file, sometimes referred to as the standard charge file, the CDM file with the negotiated charges, and that list of shoppable services, which CMS said could be deployed as an estimation tool or a shoppable file. And as we highlighted there in some of the initial stats, our initial assessment really covered both components. But it's the standard charge file that appears to have the area of the highest number of deficiencies, if you will, where there's just a lot of missing data with that standard charge file. I think a lot of hospitals had reservations about it. It's also a very complex file to put up. And the shoppable file, I think, as we all know, is really oriented more towards the patient as the consumer of the data. But hospitals and payers are really going to be the primary user of that standard charge file. And this is where publishing that data is going to make it easier to compare. And CMS was very clear. They want this data to be more public because they think that will be one way with increased publicity. It's going to be one way for hospitals or payers, if you will, CMS, others, to really slow the rate of growth. And this, because of the complexity and because of the concern, it's probably the reason why most hospitals are slower to actually meet that particular mandate requirement. So we're going to go through some examples of what we've seen out there in various files. But before we do, I did want to just walk through very quickly our approach as it relates to how we've worked with our clients based upon our interpretation of what CMS should be requiring, what hospitals should be doing. It really needs to include those 5 components. The gross charge is going to be your hospital CDM and all inpatient and outpatient services where you have a negotiated package price, and that service or package price is not going to be in your CDM, but it's an aggregate of all items and services. And that's what leads to that negotiated charge by DRG or by CPT code. At the CDM level, you need to post the cash price. We often found that was not listed, but that needs to be included. The de-identified min and max charge being the highest and lowest. And And that really leads us to, I think, the item of biggest concern, and that's the payer-specific negotiated charge. As Tara noted, and I mentioned a moment ago, she's going to be covering in a few minutes, that negotiated charge data is really where we're finding the biggest problem with hospitals really quite often only posting an updated CDM file with the 2020 rates, and there being 2 or 3 columns with the CDM description and a charge value. Obviously, this concept of service packaging can be really complex when our revenue cycle processes are typically based upon billed charges for the payer to then aggregate and calculate the allowable. But as Tara noted in the introduction with the revenue maturity matrix, everyone should be auditing payer remits for accurate, allowable, and calculations. And that reimbursement calculation has to be the foundational step. And this process of calculation is what you need to be leveraging for your service packaging, whether it's the detail or the line level charge. I think everyone can get behind that concept of percent of charge contracts. When we start getting into this concept of service packaging, it obviously is going to be a little bit more challenging, but I just want to remind everyone that is what CMS outlined as the requirement. So with that, Tara, let's look at some of the things, some of the examples we found out in the marketplace.
Okay, sounds good. Okay, so first of all, let's look at kind of the most common response to the standard charge file. I pulled a few examples to walk through it with you guys. So the most common way that hospitals have responded was to just post a very simple standard charge file, CDM number, maybe a description, and a price. This is the same requirement from the mandate from 1/1/2019. I expected to see a little bit of this. I didn't expect to see the numbers that I did. I think hospitals publish just a few of the basic fields that aren't meaningful to patients and really aren't comparable among other hospitals since there's no standard code. And I think they did that because they were a little bit fearful to share additional information. So for the negotiated rates, the results were mixed. Many didn't publish anything, but for those who did publish rates by DRG or CPT, APC, many just provided an average price rather than a specific payer plan code price. So I think, again, that this was just the fears that releasing this specific data for each health plan would come back and be adversely affecting them during their negotiation process. So the next one is looking at the common shoppable file. A common response to this requirement is definitely the self-service patient estimate, and we saw that with our numbers, our stats, and also saw that, I think it was confirmed with the poll we did earlier. So just over half the hospitals we randomly surveyed had a cost estimator available. Some provided a very wide range and others gave a specific cost. The estimate on the right shows a breakout of the hospital fees and the physician fees, which would certainly be helpful for patients, but that was rare. Most of the time it was just the hospital component. Okay, so now let's look at someone who did it well. Here's an example of a standard charge file that for the most part appears to be compliant. And although they were few and far between, some organizations did get it right. So here you can see we have a lot of different columns. We have the payer plan specific information. My only suggestion would be to add the NDC and a possible CPT at the charge code level. CMS did say that the standard descriptors were required. Okay, so the next one, another example of a job well done is the one we're looking at below. We've got the standard charge file, looks very similar, and then we have a shoppable file. And you can see that with the shoppable file, it does break out multiple CPTs and revenue codes per package. So for example, the CT neck spine with dye has both the CT and the drug price included. Okay, and next slide. And then I wanted to kind of talk about some of you who are a little bit more of a work in process. So we have talked with many hospitals who have said they're in the infant stage of price transparency. They don't have it together. They were late getting a vendor. They don't know what to do. They're waiting to see what others are doing. So I wanted to kind of talk through some of the things we saw that probably fit in that group. So we found some partial compliance and postings that were hard to quantify. So here's a kind of a complicated example, and I ran into this one a lot. So it looks as if the system may have hired a vendor and the site is under construction. It's confusing though, because if you click on all service items, it notes this display is not intended for patient use and gives a code and a few prices that aren't labeled. And if you select the charge master, the one that we just clicked, only one code displays and the columns aren't compliant with the CMS requirements. And if you select the shoppable items, it says no data has been published. But what's more concerning is that the columns aren't payer specific. So I'm not sure that this would be compliant even if it was populated with data. So I've been in this business for a long time and I was really confused. I finally connected the dots. I think that the data in one screen was actually should have been populated in a different screen under the shoppables. But imagine what the patient experience would be. And again, I'm not picking on this particular hospital and saying, you know, this is a bad example. I'm glad to see that people are working towards it. But just wanted to let those who are in this boat know you're not alone. And I think some of the intentions are there, and it's just, you know, hard to get moving on it. And it was hard to meet that deadline for a lot of organizations and maybe even vendors.
Yeah, and Tara, if I could jump in on this one, because I think this is a really good example of maybe people that are kind of stuck at whatever the delay might be. So what would you recommend to this hospital and organizations like this hospital that might be dependent on a vendor and are experiencing these types of delays and really non-compliance at this point?
Sure. Yep. I think there's a lot of people experiencing the delays and the hiccups. And I think the easiest thing to do at this point is just post a standard charge file and acknowledge the mandate. I know that a fully compliant standard charge file is a lot of effort. And so if that's not possible, or you're working towards that, even if the file isn't complete, show some progress. And the other thing that I think is really important is to put this on the website, make a note of it, show your intentions, be transparent in what you're doing to comply. And so on the next screen, because I think I did run into this quite a bit, and so did some of the others doing the research. On the screen, you're going to see two messages that let you know an organization is working on price transparency and it's going to be ready soon. In fact, they've gone so far as to give you the date of when it should be there. So I'm not saying these hospitals are non-compliant. In fact, I know one of these organizations has a complete shoppable file posted. It looks pretty and compliant, but they're letting you know their intentions. They're going to take it even a step further. So I believe many organizations are working on transparency and they just don't have a formal announcement. So it will definitely be interesting to see what gets posted over the coming months, and we'll certainly be following up and sharing our findings on this as well. And then one other thing I wanted to mention is that I noticed during the audit, there's a few organizations that are pushing the patients over to the payer for estimates. And that may work for, let's say in this example, a Blue Cross estimate. You could go there and maybe find out your cost from that website. But what about all the other patients that have different insurers? The mandate requires all payers and plans. So if you send a patient elsewhere, the other thing you have to worry about is you lose the ability to control the message around your price. And once the patient leaves your website, it really does decrease the probability that you'll have your service done at that site. So, you know, it's bigger than not just being compliant. Really is something that you should try and put on your website. And I think we're just going to see more and more of that, especially as Greg mentioned. I think we're at 10% a few years ago, and now we're more in the 50, 60 range. So.
Yeah, and we'll turn it back over to Greg here in a second. I would just like to point out that we have sent some in-session offers. So go ahead and check your chat bubble. If you see that lighting up, you have a message from us. Go ahead and check that out, see if that's something you're interested in. And if it is, go ahead and respond, and we'll move forward with that offer for you. So now I'm going to turn it back over to Greg, who's going to share a little bit more about what the CMS audit process is going to look like.
Yeah, so sort of building on Tara's examples, there are obviously some good examples and others that just aren't quite so good. Either way, CMS has been very clear that they will be auditing and investigating complaints of non-compliance. They've made that clear from the very start. This time last year, they published that. They've more recently provided some clarification. If they do find a hospital that is not compliant, and from our assessment over the last 3 weeks, there's a lot of opportunity for improvement there. But CMS has stated that they may, and I stress may because they did, they may request a corrective action plan. There is the option to assess civil monetary penalties or publish the penalty on their website. And CMS has said the penalty and the publication are very likely if the hospital fails to respond to its request for a corrective action plan. Now, it is noted here, CMS has already created and published a web page for individuals to report non-compliance or to submit a complaint. As they noted early on, they are going to be using their staff, and they are also going to be relying on the public and other organizations to begin feeding them with information. So in the web page that they built, they've outlined a very straightforward and a very thoughtful process. They instruct individuals to first contact your organization. So if an individual finds that you have posted a standard charge file or an estimation tool that's just not easily found, CMS is hoping those questions, those problems will be addressed in direct communication between your consumers and the providers themselves, which obviously brings up a great takeaway from today's session is, do you have an established process today for really gathering, quantifying, tracking these types of price transparency complaints? Because CMS is trying to push that back down to the local market for you guys to address those issues. If not, you know, they note that if there are price transparency related concerns, and they go on to clarify, they're not looking to gather billing problems, billing complaints issues. There are other steps for that. But they've provided to the public some specific examples of price transparency gaps. Some are very similar to what Tara covered, but they also provide other examples like barriers to access the data. If you've put up there requirements to submit information to access the data, that is not allowed. The data has to be available, especially for the standard charge file, without restriction. You can collect, and CMS said this was fine, you can collect patient demographic data to create an estimate. In other words, if you have some basic demographic and insurance information that you need to have to incorporate patient benefit coverage, you should be able to do that. But you should not have a means of collecting data or electronic barriers to that machine readable file. So CMS, I think, is in line with where the industry is. They've put tools in place. And if we've gone through and assessed, 450, 60 hospital websites, I feel certain they have team members that are going through this process. So it's certainly something to keep in mind, that this is, we're almost a month into the new year. So if you are one of those hospitals that haven't done anything, you really do need to make sure that you've got a plan in place for those complaints and potentially CMS reaching out to you.
Okay, so now let's move the discussion to how to best leverage this data for improved payer analytics. So the underlying concern is really payers using this data to negotiate lower reimbursement. Hospitals have to begin rethinking how this data is going to be used with your payer engagement. It's the same game, but just like any game, we have to think about our offense and defensive strategies at the same time.
Yeah, absolutely right, Tara. And I think that does start with, one of the base requirements for the new standard charge file, the price transparency file, is the gross charge data. And this information has been public for years from CMS as the MedPAR, the standard analytic file, as well as some states that have aggregated the data. And we know from experience with many hospitals and strategic pricing firms that they've used this data for benchmarking and establishing pricing guardrails. Charges create retail price for services, and as we know, payers negotiate discounts from charges. And this data has often been needed and used to analyze both service line and code. And in this particular example, you've got a roll-up report from a DRG case level to a service category. And I think this type of ongoing gross charge analysis will continue to be insightful with the service intensity, with patients really being treated by each hospital, as well as the general utilization of charges, length of stay. You're still going to want to look at gross charges. And this gross charge data is also going to be insightful as you start to drill into that data from a charge or a resource utilization. And in this example file that we provide to our clients, it highlights the utilization or the pricing of charges within revenue code categories for Medicare patients. So as an example, if you're looking to lower charges in a linear comparison of CDM unit pricing and this soon to be posted charge file, it really isn't a true picture of how charges roll up and compare until you really start to aggregate it together at a DRG or a service level. And I think that's going to be an important piece. Charge data is still going to be around. It's still going to be a relevant benchmark. We just need to begin utilizing it along with the negotiated charge data.
Agree, Greg. Layering it in will be so important. But people are excited. This is going to be the holy grail we've waited on forever. Payer-specific negotiated rates for your competitors. How long have you wanted those? So at a high level, you're going to want to know, are my negotiated rates high or low compared to others in the market? Then, of course, you're going to want that answer for each contract and a little bit of insight on your volumes to put that data in perspective.
Yeah, and our clients have noted in the past, many have used blinded negotiated rate data points. And as you said, the curtain's going to really be pulled back to see and begin analyzing that negotiated charge data. Other clients that we have who believe they have have had lower negotiated rates in the market with their payers have noted their plans and their hope to really use this type of data going forward, being the negotiated charge data, to help them move their rates up closer and to really close that reimbursement gap. And their plan is to really use this type of linear comparison data to really see and understand the difference, the rate differences at CPT code level or a DRG code level. And most want to download the data, the standard charge files that are out there, to begin running queries against it. And really a key thought is to see the data analysis at both that detail level, the detailed charge code level, CPT code level, and the roll-up analysis of how it impacts and comes together at a service level.
Yep. And another point I wanted to make is, you can use this data you can leverage the data to expand services by knowing the contractual rates at other regional hospitals. So for example, if you're going to open a new urgent care center and the negotiated charge file from hospitals that already have those services established, you'll probably want to leverage the data to help you make some decisions and get those rates in place. Similarly with complex services, chemo, cardiac, whatever it is you may be adding this new. A big piece that's missing with the data that will be posted is market share or some type of volume. So you can scrape the websites and you may see rates that look really favorable, but keep in mind that you don't have the volumes that go along with that. And we know those two go hand in hand. So that service may have a very different rate from your organization, and it may all be volume driven.
Yeah, absolutely, Tara. And you and I have discussed, the valuable insight that this type of comparative data is going to bring to the payer negotiation and the strategy process for years. And as a level set, I think we also need to think about our payer scorecards as we go forward. Hospitals will need clear, concise roll-up reporting of payer activity and performance. This includes both payer to payer and within specific payer contracts with a comparison of the various plans. We're still going to need to assess that volume and payment accuracy. And when underpayments occur, we'll need to know where additional revenue recovery opportunities come into play. And our client scorecards are really going to become a more integrated process with the patient underpayment obligation, along with denials and contractual variances, with patients, especially through price transparency, becoming the third largest payer behind Medicare and Medicaid. Organizations are really going to have to understand those payment trends. If a payer is pushing more and more patient responsibility your way, and patients aren't paying their bills, you're going to need to know this, and you're going to need to use it as a leverage point in the negotiation. It's going to be important to really consistently evaluate your payer results, tying it back to that initial contract model. As an example, taking into account your cash price and that patient responsibility is going to be one of those factors that you've got to incorporate into your scorecard analysis. It's going to be key pulling all this data together. Payers are going to want to know how they stack up. You're going to want to know how you stack up. Each side is going to look to try to either lower rates or increase rates. So as you put together your offensive strategy, really knowing how each payer stacks up before you begin the negotiation process is going to be real key to your plan on a go-forward basis. So in terms of the comparative analysis of gross charge and the new standard charge files, the payer scorecards, those are all insightful, but it's also important to just note that all of that analysis that we'll be doing is off of static data. In the last couple of minutes of today's session, we really want to move the discussion to begin looking forward at how to really leverage dynamic what-if calculations that may help you drive financial improvement going forward into 2021 and 2022. We'll be expanding on this topic in terms of dynamic modeling, contract negotiation, strategic pricing in follow-up webinars the next couple of months, because it's a real important concept that we need to start to really get our head around and start to incorporate into our revenue cycle processes.
Absolutely. So let's take the negotiation strategy a few steps forward. So as an example, what if you could insert your competitor's rate into your claims data and understand your estimated revenues using your competitor's reimbursement rates? So for example, we gain X million if we move hospital A's Aetna rates, or probably more realistic, we'd lose X million if we move to Cigna's, things like that. Scary, I know, but if this data is going to be out there and the payers are going to be using it, it will be to your advantage to understand it and play the offense. So I'm going to fast forward. Let's go to the modeling lesser of impact, the next slide. I know we're a little bit tight for time. So we just talked about using your competitors' rates combined with your claim data. Now let's think about using your competitors' charges with your current contracts. What impact would that have on your lesser charges hits and outlier hits? You know, until these terms get negotiated out of your contracts, you're going to need to continue to monitor and analyze ways to keep this language from chipping away at your bottom line.
Yeah, great example, Tara, because, you know, historically hospitals have thought about lesser of contract terms in the context of increasing or decreasing charges. And really going forward, the modeling of the competitors' negotiated rates through the claim history will provide new insight with how we really need to adjust either or both charges or those base rates or the negotiated charge, if you will.
So when the curtain comes up and the payers can see all the other payers' reimbursement rates, they're going to want to use it to tip the scale in their favor. They've got resources to analyze this data, so it's going to be up to you to come armed with that data as well. So we need to accept the fact that price transparency is here, and while some organizations are dreading negotiating now that payers have more information, we have heard from other providers that they recognize the need to really be on top of it. And again, we continue to say the offensive and defensive strategy is just going to be really, really important.
Yeah, and as I covered earlier, a new part of this reality and accepting the reality is just the recognition of the new rules. With new rules are going to come new audits and a new process for management of complaints. Really shouldn't be very far behind. So regardless of whether your organization's posted a file that's compliant or not, you really need to have a plan to move towards being compliant and then staying compliant. Based upon the complexity of hospital charges, billing, contractual reimbursement rates and terms, it does make sense to start to align your team members, and more importantly, ensure that you've aligned with a vendor that really does specialize in contractual reimbursement calculations. As you go forward, it's going to be important to make them a part of that team.
Well, what we've outlined today are specific technical and strategic steps to not only be compliant, but also a few steps for your improved financial success moving forward this year and into the next. To really win going forward, you've got to adapt, you've got to be strategic, you have to have a plan that'll work for you, and you need to keep updating that plan as more data comes out and the game changes around you. So thanks everybody for your time today.
Absolutely.
Thank you, Greg. Thank you, Tara. Great insight today. Great overview of kind of where the market is in the early stages of this mandate. We have about 3 minutes left, and I'd like to use those 3 minutes to pose some questions to you guys. We've gotten some great questions in from the audience over the session. We might run a couple minutes past 3 Eastern. If you need to sign off, completely understand. But for those who want to hear the Q&A, let's kick that off. So first question, and this is a really good one, probably on a lot of people's minds. Do you think these requirements will change with the new administration in place?
So I'll jump in first, Tara. So we would say yes, but the changes are likely going to be with smaller things, with formatting, with increased clarification for data standardization. We don't see a Democratic administration really moving away from a consumer-centric approach to healthcare price transparency. It's important to just remember that the prior administrative executive order was really largely based on the Affordable Care Act or the Obamacare guidelines. So, you know, if anything, we would expect to see more of a move towards AmSurge, professional services, other areas to be incorporated into price transparency, no different than payer rules were recently published we think this is here to stay. If anything, it may actually move a little sooner than slower. Other questions, Brad?
Sorry, I was on mute there. Yeah, we do have another question. So have you heard of any audits so far from CMS?
I'll take that, Greg. No, not yet. But I get that question frequently over the past couple of weeks. So we have not heard of that, but they did outline their audit process in a Q4 update, like December 18th, I believe. So we expect they're going to follow their process and have people reviewing their websites. They'll have quite the task because there's a lot to review. We know that because we tried to do it ourselves. But if you feel your organization isn't compliant, Greg touched on making sure that you really have a plan, and I talked about communicating that. And it really is time to put that in action to try and get compliant. If you don't have a plan, reach out and we can schedule a call.
Great. And then final question, which I think is a great wrap-up question as we move forward. What do you think will be the next phase of price transparency?
So kind of a first thought is I think we'll see an increase from 300 shoppable services to a larger number. So I think we'll see shoppable services, the estimation tool having to be built out to include more things. And I think we'll also see more improvements in terms of standardization, as I mentioned a moment ago, with the data itself.
And Greg, I'll just jump in. I would agree with all of that as well. But I think the professional services component could be next in line. I know it was very vague and confusing, especially today for HOPD sites. And we had a client that really struggled with, should we post this? How is, are we sure this isn't included? It was just vague. So I think they may push the professional side as well next year.
Completely agree.
Right. Well, I think we'll wrap up there. I want to thank everyone for spending an hour with us this afternoon to kind of better understand how hospitals have responded to this. I think there's still some work to be done, and we are absolutely available as a resource to help anybody on the call that needs help with price transparency. So those are my closing thoughts. Greg, Tara, any additional thoughts from you guys?
I would just say have a plan. CMS will be asking for what your plan is. So if you have any doubts with your process being compliant, if you don't have a plan, reach out. Let's schedule a call. Have a great year.
Thanks, everyone.
Thank you, everyone.